Alrighty, did everyone get through the questions? Yes.
Yes.
Okie doke. We will move on with the large group lecture. So like I said, we're going to be covering the small bowel today. We will go over anatomy and physiology of the small bowel, and then cover topics including small intestinal benign neoplasms, small intestinal adenocarcinoma, small intestinal malignant neoplasms like carcinoids, and then some miscellaneous topics like mesenteric cysts and Meckel's diverticulum, and then journal club. The topics that aren't going to be covered this year, these were included in the year 1 curriculum, are small bowel obstruction, paralytic ileus, pneumatosis, and mesenteric ischemia. All of these are very high yield topics for the app site, so I just wanted to put them up here for you guys to be sure to review on your own. So anatomy of the small bowel. The small bowel extends from the pylorus to the ileocecal junction and is approximately 4 to 6 meters in most adults, or 270 to 290 centimeters, and is composed of the duodenum, the jejunum, and the ileum. Arterial supply of the small bowel comes mostly from the SMA, except for the proximal portion of the duodenum, which is supplied by branches of the celiac, or the gastroduodenal artery. Venous drainage for the small bowel is through the SMV, which joins the splenic vein to form the portal vein. Lymphatic drainage of the small bowel goes through Peyer's patches of the distal small bowel to mesenteric lymph nodes adjacent to the mesenterial arterial arcades. From there, it goes to the cisterna chyli, or the abdominal origin of the thoracic duct, and it's located to the right and right behind the abdominal aorta. From there, it goes up the thoracic ducts and ultimately empties into the venous system at the confluence of the left internal jugular and the left subclavian veins. The lymphatic drainage of the small intestine, it really constitutes a major route of transport of the absorbed lipids into our circulation, and similarly plays a major role in immune defense and also in the spread of cells arising, like cancer cells arising in the gut. So duodenal anatomy. The duodenum runs from the pylorus to the ligament of Treitz and is roughly around 20 centimeters. It's divided into 4 portions. The first portion, the duodenal bulb, is the first 2 to 3 centimeters and is completely intraperitoneal. It is anterior to the GDA, and it's where 90% of duodenal ulcers occur. The second portion of the duodenum, or the descending duodenum, includes the ampulla of Vater. The third portion, or the transverse duodenum, crosses across the vertebral column. And the fourth portion, the ascending duodenum, joins the jejunum behind the ligament of Treitz. The descending and the transverse portions are retroperitoneal. The blood supply to the duodenum. The superior portion of the duo is supplied by the posterior superior and anterior superior pancreatico-duodenal arteries from the GDA. The inferior portion, on the other hand, is supplied by the posterior inferior and anterior inferior pancreatico-duodenal arteries that come from the SMA. So the superior portion comes from the GDA, and the inferior portion comes up from the SMA, just like the rest of the small bowel. The transition point between the third and fourth portions of the duodenum occur at this acute angle between the aorta and the SMA. We aren't really covering this topic this year, but what is obstruction at that transition point called? Maybe team 4, do you guys want to give it a stab?
We would refer to it as SMA syndrome.
Yep, exactly. SMA syndrome. It's essentially compression of the third portion of the duodenum between the SMA and the aorta. So the jejunum and ileum, unlike the duo, is all intraperitoneal. There's no distinct anatomical distinction between the ileum and the jejunum, but relative to the ileum, the jejunum has a larger diameter, usually a thicker wall, more prominent plicae circularis, or the transverse folds in the mucosa of the small bowel, and usually a less fatty mesentery and longer vasa recta. So a quick anatomy review. Team 3, do you guys want to go over this?
Are we on?
Can you hear us?
Yep, we can hear you.
Go ahead, John, you're it.
All right. We're just going through this. Oh, arterial supply of the small bowel. It's going to be the SMA.
Yep.
Vast majority.
Except for?
Except for at the very end, you have like the ileocolic, I guess. Which is,
Well, it's the SMA, except for the proximal duo, which is supplied from branches of the celiac. It's supplied by the GDA.
The venous drainage is from the SMV, which joins with to form the portal vein.
Yep, perfect.
Retroperitoneal portions of the duodenum includes the ascending portion and the proximal portion. I can't remember the second one.
So it's usually the descending and the transverse that are retroperitoneal. And then the transition between the third and the fourth segment of the duo marks that transition.
We're saying ligament of Trice.
Ligament of Trice?
So the ligament of Trites usually marks the distinction between the fourth portion of the duo and the jejunum. Or what I was getting at here was there's an acute angle between the aorta and the SMA that marks the transition between the third and fourth portion of the duo. And that acute angle is sort of where you can have SMA syndrome form. And then how do you distinguish between the jejunum and the ileum?
I'm going to say plicae circularum. What do you guys think?
you also have the longer arteries.
I think it says arcade. You can see the arcade. Okay. Yeah.
Yep, you're right. So the jejunum usually has a larger circumference that's usually thicker, larger vascular arcades with long vasa recta, versus the ileum has smaller or multiple arcades that give off shorter vasa recta. Okay. And then in terms of the microanatomy, the mucosa is divided into 3 layers: the epithelium, the lamina propria, the muscularis mucosa. The epithelial layer is a continual sheet of epithelial cells that cover the villi and lining of the crypts. Microvilli really increase the absorptive surface of the small bowel by a phenomenal magnitude. They increase the surface area to about 30 square meters. The muscularis mucosa is a thin layer of muscle that separates the mucosa from the submucosa. The submucosa then is a layer of fibroelastic connective tissue that contains blood vessels and nerves. It's the strongest component of the intestinal wall, and that's why it's really important that you include it when you're creating a anastomosis. The muscularis layer consists of a thin outer longitudinal wall and a thicker inner circular layer of smooth muscle. And lastly, the serosa is the outermost layer and is continuous with the visceral peritoneum. So quick review again. Sir Jonk, what is the strongest layer of the small bowel? Yep, submucosa. And then cells of the small bowel. Team 5, do you guys want to go over these? Just real quick about what each of the functions of each of these cells would be.
Huh?
I think you guys tried.
Hello?
Yeah, that's better.
Well, I think the goblet cells are like the mucus-producing cells.
Mm-hmm. And the enterocytes are mostly absorptive cells. Goblet cells secrete mucin. They protect the mucin, and the mucus protects the mucous membranes. What about enterochromaffin cells?
Oh, is this small bowel?
Yeah.
So they produce serotonin, and they help with motility and secretion of other neurotransmitters as well. Brunner's glands?
They're alkaline producing?
Yep, exactly. They make alkaline solution. Paneth cells.
They're in the crypts of Lieberkühn?
Exactly. They secrete antimicrobial peptides, and they are found in the crypts. And then lastly, Peyer's patches.
like an immuno, they do have immune function. They're important in certain types of immunity.
Yep, they're lymphoid tissue, most prominent in the ileum. Nice job, guys. So the GI tract is, the small bowel is the body's largest endocrine organ, and it releases more than 20 different regulatory peptides and hormones that influence a large number of physiologic processes. And it acts on tissues including exocrine glands, smooth muscle, the peripheral nervous system. Most of these hormones are sensitive to the gut nutrient content and regulate hunger and satiety. And we could have a whole other lecture on GI hormones, but here are some of the high yield summaries of the main ones. Gastrin is secreted by G cells in the stomach. That memorization is easy, G for gastrin. And it essentially stimulates gastric acid secretion and stimulates growth of gastric mucosa. Cholecystokinin is made by the eye cells in the duodenum and the jejunum, and it's stimulated by fatty acids and amino acids to secrete pancreatic enzymes and stimulate bile growth, bile flow. And then secretin is secreted by the S cells in the duodenum. They are stimulated by acid in the duo and increase pancreatic bicarb secretion. So that makes sense. When the S cells see acid, they're going to tell the pancreas to secrete more bicarb. Some other high yield gut hormones. Motilin is secreted by the M cells in the upper duo during fasting states, and it initiates the migratory motor complex. The pancreatic polypeptide is released from PP cells, and it's an antagonist to CCK. Enteroglucagon is released from intestinal cells and in response to decreased blood sugar, and it initiates glycogenolysis and glyconeogenesis in the liver. Glucagon-like peptide is produced by L cells in the small intestine. It stimulates insulin secretion. And finally, somatostatin, which will come into play later, is produced by D cells, and it's essentially the great inhibitor. It inhibits secretion of all other GI hormones and gastric acid secretion. So the intestine has a remarkable ability to absorb and secrete large quantities of fluid. Team 4, this was one of the small group questions. The small intestine typically reabsorbs what percentage of fluid that passes through its lumen?
We were surprised to learn that it is, in fact, 80%.
Yep. It reabsorbs approximately 80% of fluid that passes through. And then every year, there's almost always a question on the ABSITE about where certain nutrients are absorbed. The high yield takeaway is that iron is absorbed in the duo. Folate and fat-soluble vitamins are absorbed in the jejunum, and B12 and bile salts are absorbed in the ileum. So quick physiology review of all of that. Let's see, Team 5 did the last one. So let's have, did Team 5 do the last one, or was it Team 3? Let's have maybe Elmhurst go through the physiology review.
Our volume working?
Yep.
You hear us? Cool.
Yep.
Someone go first. Okay. I'll start, but interns get involved, or Christian. Strongest layer is the submucosa.
Yep.
Okay. Guys, anyone?
Goblet cells.
Yes. Goblet cells. I heard mucus from the crowd.
Yep.
Enterochromatin cells, guys. Anyone? Yep. Serotonin precursors, I heard.
Yep, serotonin and serotonin precursors.
Brunner's glands. Yes.
Material?
Alkaline solutions. Okay.
Yep.
Okay, where are they secreted in the action? Gastrin?
G cells.
G cells? Stomach. Okay. CCK? I heard I cells. Where are they? Where are they, guys? Anyone? They hear duo?
Yep.
Um,
And what do they do?
Oh, what do they do?
Contract all the time.
What do they do?
Call ladder.
Yeah, they call
Track.
They call us contract.
Contract.
Good job.
Simply called
Okay, secretin. SLs.
secretin.
And they call anyone, guys, yell it out. There's literally mics in front of all of you guys. You can just yell it out.
It helps with the secretin.
All right. And somatostatin is D cells, and what does it do?
Stops everything.
Stops everything. Good. Okay.
Exactly.
Okay. And then absorption. What does the duo absorb? Iron. Good. Jejunum.
That's soluble.
Okay. Good. And then ileum is what?
B12.
Okay. Good. B12 and bile salt.
Job.
Nice job, guys. Okay. So moving on to some of the main small bowel topics that we want to cover this year in the year 2 curriculum. So small bowel neoplasms are fairly rare. They are primary and metastatic tumors of the small bowel and make up less than 2% of all GI neoplasms. Approximately 9,100 new cases per year. So despite the fact that they're very rare, they do show up very often on the ABSITE. The mean age of diagnosis is around 62 years. And the presenting symptom of jejunal and ileal tumors is usually obstruction versus the presenting tumor of a duodenal, presenting symptom of a duodenal tumor is usually pain, biliary obstruction, gastric outlet obstruction with nausea and vomiting, and occult bleeding. So benign small bowel.
Shruti, this is actually an important question. What is the most common neoplasm of the small bowel?
So the most common neoplasm of the small bowel, it depends on malignant or benign. Benign neoplasm, the most common is a leiomyoma, versus malignant, adenocarcinoma and carcinoids are the most common.
Okay, so make sure, is it metastatic adenocarcinoma or primary adenocarcinoma?
Metastatic adenocarcinoma.
Okay, so let's talk. When you talk about small bowel neoplasms, you have to make sure you're looking at primary and metastatic. So what is the most common metastatic small bowel neoplasm?
So the most common metastatic tumor to the small bowel is melanoma.
Okay, good. And what are the others that do metastasize to the small bowel?
So breast, lung, ovarian will metastasize to the small bowel.
Exactly.
Yep. Nice. So benign neoplasms of the small bowel, like we were saying, include leiomyomas, adenomas, lipomas, and hamartomas. Malignant small bowel tumors include adenocarcinoma, primary and metastatic, carcinoids or neuroendocrine tumors, lymphomas, leiomyosarcomas, and quick review again, Dr. Davino just went over this, but what is the most common metastatic tumor to the small bowel? Maybe the VA? I think their microphone might not be working, but like we just said, melanoma is the most common metastatic tumor to the small bowel. So small bowel benign neoplasms, small bowel tubular adenomas, similar to colonic tubular adenomas, are benign, but they have an increased risk of malignancy with villous features and larger size. The most common symptoms for small bowel tubular adenomas include bleeding and obstruction, and they can be endoscopically resected, but if they're found to have carcinoma in situ or harbor any malignancy, then a formal resection is required. Brunner's glands adenomas, remember Brunner's glands were the cells that secreted alkaline solution. So these tumors secrete bicarb-rich fluid, and they have similar malignant potential as tubular adenomas. Usually a endoscopic resection is adequate, and it's mainly done to prevent intussusception or obstruction. Leiomyomas, unlike the tubular and Brunner's gland adenomas, usually require a resection because it's very difficult to distinguish from a GIST or a leiomyosarcoma. So leiomyomas of the small bowel require resection. And then hamartomas are often seen in Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is characterized by multiple GI hamartomas and mucocutaneous pigmentation. The hamartomas very rarely undergo malignant transformation, so you only really need to resect them if they are symptomatic or enlarging. These patients, however, do have an increased risk of several cancers. They have an increased risk of gastric, colonic, prostate, and ovarian cancer. And then small bowel adenocarcinoma. So talking about malignant tumors of the small bowel now. Small bowel adenocarcinomas arise from adenomatous precursors like they do in colon cancer. It most commonly occurs in the duo. We don't exactly know the pathogenesis for why it's most commonly in the duo, but the theory is that the carcinoma cascade is activated by the mixing of ingested carcinogens with biliopancreatic secretions in the duo. So that's one of the theories for why adenocarcinomas of the small bowel are most common in the duodenum. Risk factors include smoking, alcohol, familial syndromes like HNPCC and FAP, and Crohn's disease. When a Crohn's patient gets small bowel adenocarcinoma, it's 70% usually occurs in the terminal ileum as opposed to occurring in the duodenum. And the most common presenting symptom for small bowel adenocarcinoma is actually abdominal pain, very vague pain that isn't picked up until later stages of the disease. In terms of treatment for small bowel adenocarcinoma, the goal for surgical resection is complete resection with negative margins and a lymphadenectomy, so at least 10 lymph nodes. You want your resection margins to be about 5 centimeters distally and proximally. In the second portion of the duo, you may require pancreaticoduodenectomy depending on the location of the lesion. And if the lesion is in the terminal ileum, then you would require a right hemicolectomy. The prognosis is completely dependent on stage at presentation. 5-year survival for stage 1 disease is around 50%, versus 5-year survival for stage 4 disease is around 5%. And use of neoadjuvant chemoradiation for small bowel adenocarcinoma is still very controversial. So you won't get any questions on that on the app site. Small bowel carcinoids. So there are many forms of neuroendocrine tumors, but for the small bowel, we will focus on carcinoid tumors. Carcinoid tumors, like we were saying, arise from enterochromaffin cells. They are mostly non-functional, indolent, and often asymptomatic. They are commonly found in the appendix and sometimes incidentally found during an appendectomy. And they present with vague abdominal pain, but usually present with vague abdominal pain, but can also have obstructive symptoms from a desmoplastic reaction that occurs when they grow into the submucosa and kink the mesentery. So on imaging, they're often associated with a fixed and angulated appearance and foreshortening of the mesentery and mesenteric vessels. They can secrete several vasoactive substances, including serotonin, histamine, prostaglandins. Carcinoid syndrome occurs due to a release of some of these vasoactive substances that are secreted by tumor cells. It causes flushing, diarrhea, bronchoconstriction, and right heart valvular fibrosis. These substances are often metabolized in the liver, so the tumor must have bypassed the portal or hepatic circulation for the patient to actually develop carcinoid syndrome. So that occurs when the patient has either bronchial carcinoids, retroperitoneal mets, or hepatic disease that overwhelms the MAO system in the liver.
Any other sites that could cause it without it being present in the liver? Any other organ system where there's spread of the disease other than the liver causing carcinoid symptoms? Think of the areas that have dual blood supply.
So retroperitoneal disease.
Right. What else?
Bronchial carcinoid.
That's right. Lung. What else? Ovarian metastases can do that as well.
Got it. So bronchial carcinoids, retroperitoneal, mets, and ovarian disease can cause carcinoid syndrome without having hepatic disease. And then in terms of diagnosis, tumor markers, imaging, and functional testing with high urinary 24-hour 5 HIA can be used for diagnosis. The highest sensitivity for detecting carcinoid is actually chromogranin A level, and that's sort of a buzzword for carcinoid on tests. In terms of treatment, only about 20% of patients have resectable disease at the time of diagnosis. At laparotomy, about 30% of patients will have synchronous lesions, so it's very important to run the entire bowel and perform an en bloc resection when possible. Octreotide or a somatostatin analog should be started before anesthesia and continued on the next day to avoid carcinoid crisis. For appendiceal carcinoid, if the tumor is less than 2 centimeters and is at the tip of the appendix, then an appendectomy can be sufficient. If it's greater than 2 centimeters or at the base, then you'll need a right hemicolectomy. For a duodenal carcinoid less than 1 centimeter, you can actually undergo an endoscopic resection. 1 to 2 centimeters, you can enucleate. Greater than 2 centimeters will require a formal resection, possibly a Whipple. And this is, the reason that they allow endoscopic resection and enucleation for duodenal carcinoids is largely because of the morbidity that would be involved with a formal resection.
Let me just add, Shruti, just to be very specific. Appendiceal carcinoid, you're absolutely right. Those are the parameters. This comes out in the AB site every year, but you have to be very careful that even if it's less than 2 centimeters, with some unfavorable characteristics, such as serosal invasion as well as mesoappendiceal invasion, warrants a completion right hemicolectomy. And in 20%, and probably in most of the time you do the completion right hemicolectomy, there's no residual disease, but it is important to, decrease the incidence of recurrence. So even if 2 centimeters is the magical number, you need to do, to talk to pathology to look at some, characteristics of the tumor itself that may warrant a more extensive resection. Okay, and in the small bowel, what are your margins? Do you do margins? What's your goal in small bowel resection?
So you want a R0 resection, and you want to do an en bloc. In terms of margins, I don't think there's a consensus on exact margin, but you should have no tumor at ink, like on the margin.
Exactly. It's just you do your lymphadenectomy because it's usually associated with mesenteric nodes, and it also gives you prognostic indicators, but there are no specific margins on either side of the small bowel as long as you can clear it.
Yep, exactly. Thank you, Dr. Davino. So again, Dr. Davino pointed out that for appendiceal carcinoids, 2 centimeters is the cutoff, but you definitely need to watch out for other high-risk features like lymphovascular invasion that will warrant a formal right hemicolectomy. And then moving on to GISTs, or gastrointestinal stromal tumors, these are essentially slow-growing submucosal sarcomas. They arise from the interstitial cells of Cajal and occur due to a c-KIT mutation. The small bowel is the second most common site for GISTs after the stomach. And unlike other small bowel tumors, GISTs often actually present with symptoms early. They present with nausea, vomiting, abdominal pain, distension, and that's why these tumors are often caught fairly early on. High-risk features include greater than 5 centimeters in size or greater than 5 mitoses per high power field. If the tumor has these high-risk features, then it does require neoadjuvant imatinib or Gleevec. That's a tyrosine kinase inhibitor. For patients who have tumors that are less than 5 centimeters in size, they typically have a very low rate of recurrence, less than 10%. And so if they're completely resected, they don't require any adjuvant therapy. When talking about surgical resection for GISTs, surgical resection is very much the primary treatment of choice. You don't require wide margins, you just need to resect the tumor. Neoadjuvant imatinib, or giving imatinib before the tumor, can be considered in cases where the tumor is borderline resectable, if they have locally advanced disease, or they have a potentially resectable tumor if the tumor was able to decrease in size after neoadjuvant treatment. In terms of re-resection of recurrent lesions, there is new data that resection of recurrent GIST does increase survival. If the patient does have recurrent disease, then you would add adjuvant imatinib. Typically, patients tend to do really well. 5-year survival for low-risk tumors can be as high as 95%, and less than 10% for high-risk large tumors with a high mitotic rate. So it's just very important to catch that and start imatinib if they have those high-risk features. And then lastly, small bowel lymphomas. The stomach is the most common site for extranodal non-Hodgkin's lymphoma, and the small bowel is the second most common. They present with chronic symptoms like weight loss, diarrhea, dull abdominal pain, malabsorption, and risk factors include H. pylori, autoimmune disease, immunosuppression, celiac disease, and IBD. T-cell lymphomas are usually associated with celiac disease versus B-cell lymphomas are associated with H. pylori or malt lymphoma. The treatment for malt lymphoma is H. pylori eradication, and the treatment for T-cell lymphoma is chemo or radiation or a combination. Surgery is only reserved for complications like perforation, gastric outlet obstruction, bleeding, or disease that's resistant to chemotherapy. Okay, so that was a lot. Let's go over a review of the malignant small bowel neoplasms. Team 3, do you guys want to take this first review slide?
Take all her to it.
Adenocarcinoma. It's most common in the duo. It arises from the
It arises from adenomas, like adenomatous precursors.
yeah, it's most common in the duo. The resection are, I think, grossly negative.
So for adenocarcinoma, you do want a 5-centimeter resection margin. You want an R0 resection for carcinoids, but adenocarcinoma, you do want 5-centimeter margin. Sir Jonk, do you want to take the carcinoid questions? They arise from the enterochromaffin cells. What's the most common location? Appendix. And then what is the highest sensitivity test for detecting?
Chromatographin A.
Yep, chromographin A. Good job. And then GISTs. Team 4, do you guys want to take these?
Just arise from most common location would be like a gastric mucosa.
Can people speak a little louder? Nobody can hear anything.
I believe they arise from the submucosa. Most common location is that within interstitial cells, it's called. Most common location is
Yes, you're right.
in the stomach. High-risk features include tumor rupture, size greater than 5 centimeters, greater than 5 mitoses per high power fields.
Yep, so tumor rupture doesn't really happen that often, but the high-risk features that you most often look for are size greater than 5 centimeters and greater than 5 mitoses. Yep.
Adjuvant treatments with Gleevec.
Yep, Gleevec or imatinib. And then
for small bowel lymphoma, lymphomas are associated with H. pylori. And treatment for, and T-cell lymphoma, I believe associated with Crohn's, autoimmune disease.
Yeah, exactly. So T-cell lymphoma is not associated with H. pylori. T-cell lymphoma is associated with autoimmune disease, celiac disease. Yeah.
Oh, no, I said that malt was associated with H. pylori.
Oh, okay. Got it. Yes, malt is associated with H. pylori. And then treatment for malt.
Treatment for malt would be just the triple therapy associated with H. pylori treatment.
Yep, H. pylori eradication with either triple or quadruple therapy. Okay. So now we'll cover a couple miscellaneous small bowel topics that sometimes come up on the ABSite. Mesenteric cysts are rare, benign intra-abdominal tumors. The incidence is about 1 in every 250,000. They're thought to arise from ectopic lymphatics or obstruction of lymphatic channels. And the symptoms, most of these patients are asymptomatic, or they have vague complaints of abdominal distension or pain. Oftentimes, these are seen incidentally on imaging. Complications with really large mesenteric cysts can include obstruction, volvulus, infection, or rupture of the cyst. Treatment, usually when you find these incidentally on a CT scan, it doesn't warrant any treatment. But if they do cause any symptoms, you can enucleate if it doesn't compromise the bowel vasculature. Otherwise, a segmental bowel resection is required. If it's located deep at the root of the mesentery, then a partial enucleation with marsupialization of the cyst is what you need to do. And then Meckel's diverticulum, another sort of miscellaneous small bowel topic that comes up. Meckel's diverticulum is the most common congenital small bowel anomaly. It accounts for about 25% of small bowel diverticulae. A Meckel's diverticulum occurs because of it's essentially a failure of the vitelline duct or the omphalomesenteric duct, which connected the embryonic midgut to the yolk sac. It's a failure of the vitelline duct involute. It's a true diverticulum. It usually occurs at the antimesenteric border of the ileum and contains all layers of the intestine. So the rules of 2 for Meckel's diverticulum, it usually occurs about 2 feet from the ileocecal valve. It occurs in 2% of the population. It's twice as common in males. It's often symptomatic within the first 2 years of life. It includes 2 types of mucosa, gastric mucosa about 75% of the time, and pancreatic mucosa about 15% of the time. And gastric mucosa is more likely to bleed versus pancreatic mucosa is more likely to cause diverticulitis. 2 symptoms, typically bleeding in children, and that happens with gastric mucosa, versus obstruction in adults. A Meckel scan can be used for diagnosis. It's a technetium-99 pertectinate scintigram that essentially identifies gastric mucosa, mucus-producing cells. So Meckel's diverticulum with ectopic gastric tissue would be picked up by a Meckel scan. And then in terms of treatment of Meckel's diverticulum, if found incidentally, most studies recommend leaving it alone. You can do a diverticulectomy for uncomplicated diverticulitis, or a segmental resection for complicated diverticulitis or diverticulitis involving the base. Most often, people will advocate for a segmental resection for bleeding because the ulcer that's causing the bleeding is usually on the anti-mesenteric border and not always included in the diverticulum.
So, Shruti, what would make you resect it more if you found it incidentally? Are there any characteristics of a Meckel's diverticulum that would make you more likely to decide to resect it?
So if it has if you're concerned for gastric mucosa and bleeding, you want to resect it because like the ulcer that's causing the bleeding is usually not contained within the diverticulum.
But remember, we said this is incidental. So the patient is asymptomatic. You don't know if the patient's bleeding.
For asymptomatic patients,
You're exploring a patient for some for some other issue, and you find a Meckel's diverticulum. Patient's 42 years old. Anybody, and you will encounter this. What characteristics of the diverticulum will make it likely for you to resect because you think it's probably going to be associated with a 20-30% incidence of subsequent complication?
I'm not sure. So if they have a narrow neck.
That's right, exactly. Things that would predispose it to having obstruction or, things like that. If it's a broad base, you usually leave it.
Got it.
Unless you don't find any other pathology in the belly on some exploration. Okay, and it's easy enough to take a TA stapler and staple it. But if there's no indication, you leave it alone because that's the site where you could have a leak if it happens. So usually broad-based diverticuli are left alone because nothing can get it. Chances are it's not going to be obstructed. You're not going to know whether it's bleeding or has gastric mucosa unless you send it for pathology. Also, you have to realize that it usually is in the antimesenteric border. But if it's a large diverticulum, the changes in the wall of the small intestine can extend so that it's almost overlapping to the mesenteric side. So you have to be very, very careful when you're doing a localized diverticulectomy for this.
Mm-hmm.
And Shruti, one other thing. So obviously in pediatric surgery, we see a lot of these because if somebody's going to have ectopic, gastric mucosa, it's probably going to present earlier in life rather than later in life. And
right.
Most of the teaching and literature nowadays in pediatric surgery, at least, which I think goes for all of general surgery, is that ulcer that's on that antimesenteric border is going to heal once you take away the inciting factor of the acid production. So we no longer, are taught as pediatric surgery fellows or pediatric surgery residents that you need to do a small bowel resection if there's an ulcer, because that ulcer, as long as, with the caveat of what Dr. Davino just said, as long as that ulcer, you're not concerned that it's extending throughout the entire circumference of the small intestine, that ulcer bed is going to heal once you take away the diverticulum. So we most of the time are just doing diverticulectomies now, with the caveats of the things that we've already talked about, as far as if the base seems like it's involved, if it's extremely wide and you're going to end up narrowing the lumen of the remaining small intestine. But the ulcer itself doesn't necessarily play into whether we need to do a resection or not.
Got it. That's a really good point. Thank you, Dr. Tackett. Okay. And then lastly, so keeping in mind that what Dr. Davino said, a narrow base is going to be more, you're going to be more suspicious of complications like obstruction, and you want to resect that even in asymptomatic patients. And then what Dr. Tackett said, for pediatric patients, even if they have a bleeding ulcer, that will usually heal once you remove the diverticulum. So they're advocating for diverticulectomies as opposed to segmental resections when possible in pediatric patients. So the rule of twos, let's have, does the surgery library want to go over the rule of twos quickly? Or the people in the consult room?
Can you hear me?
Yep, we can hear you, Amira.
So 2% of the population, 2 feet in the ileocecal valve, 2 times more likely in males, 2 types of like tissue, so pancreatic and gastric.
And which one's more common?
I think we said is gastric more common?
Yep.
I feel like I'm missing some stuff.
So 2 symptoms, bleeding versus obstruction. And I think you got the rest, 2 feet from the ileocecal valve. Good. So that covers all of the topics for small bowel for this year. I think because we have some time, we should go over some of the review slides again as a group before moving on to Journal Club. How does that sound?
Before you leave small bowel, Shruti, the other thing that you also that comes out on the website are the other types of diverticulum in the small bowel, which does exist other than Meckel's, okay? And depending on where the site is, you have to know whether it's a true or it's a false diverticulum. And I think you don't need to cover it here, but people on their own should read that because the implications of treatment as well as the outcomes are very different. A small bowel, you know, a jejunal diverticulum as opposed to a duodenal diverticulum, as opposed to an ileal diverticulum, which you will find. Okay, and there are the epiphrenic diverticulum, the traction diverticulum. All of those are famous questions in the website. And also, not only for the sake of the questions, but it's important to know so that you understand what treatment, how you treat those types of diverticulum.
Right. So guys, just make sure you look into diverticula of the small bowel in general, not just Meckel's diverticulum. What I can do is I can also create a short review slide on that and send it out so people have that for the future. And then let's just go through the anatomy review again. Sir John.
It's the SMA, except for the first 2 centimeters or something of the duodenum.
Yep. So the SMA is the arterial supply for the small bowel, except for the proximal duo, which includes supply from the celiac or the GDA. Venous drainage of the small bowel.
It's the S&P.
Retroperitoneal portions of the duo.
The descending and transverse.
Yes, descending and transverse. Transition between the 3rd and 4th portions of the duo.
This was the angle of the SMA.
Yes, the angle between the aorta and the SMA. And how to distinguish between the jejunum and the ileum.
This was the length of the vasa recta.
Exactly. So the jejunum will have long vasa recta versus the ileum will have multiple smaller arcades and give off shorter vasa recta. And then Team 4, maybe you guys can go over the physiology review.
So the strongest layer would be the submucosa. The goblet cells secrete mucin. Enterochromatin cells secrete serotonin. Is it an alkaline solution?
Yep.
Gut hormones, gastrin, secreted from the G cells, increase acidic production. CCK, secreted from the duodenum, increases biliary contraction.
What cells in the duo?
Oh, the islet cells?
Eye cells,
Secretin, also secreted from the duodenum. And S cells?
Mm-hmm.
That increases bicarbonate secretion.
Yep. And somatostatin.
Cells.
And inhibitory.
Yep.
D cells and
and sort of global inhibition of GI hormones. And then main absorption in the duo, or the duo is responsible for
iron,
Yep.
folate, ileum, it's going to be B12 and bile salts.
Yep. Nice. And then review of the neoplasms again. Team 3, do you want to go over this?
It does again. Adeno arises from adenomatous precursors. It's most common in the duo. You have 5 centimeter margins with lymphatic resection. Carcinoid is chromatin cells. Most common in the appendix. Highest sensitivity is the chromogranin.
Nice. And then who have we not called on yet? The VA, is your speaker working now? Nope. Okay, team 3.
So GISTs are from the interstitial cells in the interstitial whatever. Most common location, I think we said, was in the stomach. The high-risk features are greater than 5 centimeters and greater than 5 mitosis for high-power field. Adjuvant treatment is with imatinib, which is Gleevec. Small bowel lymphoma, T-cell lymphoma is associated with celiac. Malt is associated with H. pylori, and treatment is triple or quadruple therapy.
Perfect. Nice job, guys. So we'll take a short break, and then we'll be back for Journal Club.